would like to welcome Dr. Sagarika Patyal, and apologies for the Major General.
No, it doesn't matter. It's all right.
And I'm quite sure with her enormous experience and the rigor from the Indian Army, she'll be able to throw a great light on a very important topic and the most important surgery that we have in glaucoma, trabeculectomy. Over to you, madam.
Thank you so much. And I love being what she has made me, Hermione Granger. And so let's go back into what actually trabeculectomy is. It's been with us for a very, very long time, 1968, imagine. But do we feel that trabeculectomy has shown changes? Yes, it has started climbing steps since a very, very long time. But as on today, trabeculectomy is still the shining star that is waiting to be displaced. Lots of other things have come up, but we know what place trabeculectomy still has. So the goal of trabeculectomy is to create a long-lasting subscleral fistula. Now, why is trabeculectomy so important? Because all age groups can benefit from this procedure. High intraocular pressures can be controlled by this method. There is no need for a clear cornea or angle visualization, no need to learn many more things. But yes, you have to learn how to do the surgery and also look after that little bleb that you have formed, look after and care for it, both by the patient and also by the doctor. What is the final writing on the wall? In terms of incisional surgery, trabeculectomy is still considered to be the gold standard, with tube shunts trailing shut behind. Both trabeculectomy and tubes are well-established procedures that have been successfully employed for several decades. Although highly efficacious, now that is the problem, they are associated with intense post-operative care for the first 2 to 3 months, carry the risk of potential vision-threatening complications, and this is why we need certain amount of complications. All of us do this surgery. I'm just going to show you a little bit about how do we do it. And it's very, very simple, because we must remember what we do in order to say how we are going to, this is what happens always. Okay, so we are putting in the mitomycin, we're putting it nice with sponges, going further beyond, and after that having a thorough wash, and after the thorough wash again we go ahead and then we go into the actual cornea, and once we have identified the structures, and then after that I make it with my blade, and I don't do it with a punch, but I know a lot of people do it with a punch. Both are equally effective, and once we have done that, and then we cut a nice ostium over there, make a nice ostium, check whether the iris has actually been cut properly, the base of the iris being nice and big, and then after that go ahead, see, pick it up, pull it back, and then after that put in our sutures. And once we have done our sutures, we definitely put in our releasable sutures. And then after that here, I'm putting in my releasable suture, which is so important. And now let us go on, of course, tying the conjunctiva and seeing to it that the flow is actually on. And so now let's go on to, so there are now modifications which have come up on how do you apply the mitomycin. So in 2021, they have talked about, instead of placing it horizontally, parallel to the limbus, they are now placing it vertically, so that it reduces the size of the conjunctival wound at the limbus, preserving more of virgin conjunctiva that can be used for further repeated trabeculectomy. This was only done by one person. Obviously, we would like to have many more studies on this. Now, a subconjunctival injection has definitely come to the forefront by none other than Maheshwari and all, and many other people have started trying it, because, you found that little bits of this sponge may get left behind and result in a continuing amount of mitomycin the eye being subjected to that amount of mitomycin. So the very important method is to give a slightly lower strength of mitomycin of 0.1 milligram, 0.1 milliliter of 0.1 milligram per ml. You inject it into the tenons layer about 8 to 9 millimeters away or posterior to the limbus, little off, so as to avoid the superior rectus muscle. Of course, you have to irrigate the conjunctiva very, very well with balanced salt solution, and then with a gentle hook, muscle hook, you can just spread the mitomycin all across so that it spreads very well. Now, Dr. Sehota is also, since a long time in RP Center, they have been following this method. Instead of giving 0.2 or even going up to 0.4, where I'm sure they do only 0.4 in certain number of cases, in certain particular cases, they have found that just 0.1 milligram per ml works equally well, and it is non-inferior to the oft repeated 0.2 milligram per ml. So only thing is they've said you take a wide area of MMC in order to avoid localized blebs. And now what are the other modifications available to us? And one of them is that we can use amniotic membrane. And I'm quoting a paper of Dr. Kirti itself over here, and I've used it in several cases, and I've found that, for example, in a case of Axenfeld-Briegers, the boy who was only 15 years old, and we find that he had myopia, and I didn't know, now what should I do? Okay, AMT came to my rescue, and I'm just going to show you another modification which we all do, phacotrab. But one site, two site, I prefer the two site method. And in that also, I have been able to use micro AMT. So AMT has immense amount of use. And so just let's have a look, a very brief video as to how we have done it. And again, the same method. I like a triangular flap, partial lamellar flap, scleral flap, and go nice well into the cornea. And then after that, put in my horizontal mitomycin strips, then go to another site, do my phacoemulsification, and after that, put in my lens nicely. Then I'll close my wound, and after that, go ahead and complete my trabeculectomy. And then, of course, I found that there was a little thinning at the sclerostomy site, and therefore I took my amniotic membrane, cut it, and very simply put it over there, and you can either suture it over there with 1 or 2, but I found that, yes, even if you don't suture it, lay it out nicely, and take it in your conjunctival suture, you find that you can even do it. So this is a very good method of using in trabeculectomies. Moorfield safe surgery system, as mentioned by Kaur and all, is very good thing. And most important thing is what he says is make a rectangular scleral horizontal incision parallel to the limbus, dissecting at partial thickness scleral pocket, cutting the two sides. Don't complete your side incisions right up to the limbus, so that it helps, everything is being done in order to direct your aqueous backwards and posteriorly. And also very important is that he uses a clamp. Yes, we don't have money to use a clamp, but we try not to affect the cut conjunctiva. And then most important is that they put an adjustable suture. We all do releasable sutures. So without a releasable suture, I can't get sleep. So I prefer my Wilson's releasable suture. And as I've shown in the figure out here and in my video also, there are various other methods of putting releasable suture. One can do it the way we want. Another thing which is very much in position, which people have used for a very long time is Ologen. We know Ologen is a type 1 attocollagen glycosamine. It has a nice pore. It helps to direct the fibrosis nicely. And here is the picture of a patient whom I had done probably in AFMC long ago. And the Ologen sort of remains in position. One has to know where to place it and how much of suture tying and how much of tightening one has to do. And now, fortunately or unfortunately, Ologen has taken another person on its site. So 2 Ologens have been used by Angmo et al. In RPC, and they are placing an additional implant under the scleral flap, placed in a scleral pocket. This helps to maintain the intrascleral aqueous lake, reduces the adhesion between the lamellar scleral flap and the scleral bed, augmenting aqueous flow. They feel that it is definitely better. Now there was another add-on, which again the RPC people, they have shown us a way. In fact, with mitomycin with Ologen, subconjunctival Ologen implant they found was insufficient to achieve a low target pressure, as it covers only a small area in the conjunctiva. There was fibrosis around that. So they combined Ologen with low-dose MMC. Anti-vascular endothelial growth factors, amniotic membrane, other biodegradable implants, they prevent fibroblast action. They modify wound healing in a safer way. Now, there is another method of doing a trabeculectomy, another modification by Sihota and all, who's done it long back in 210, and I have personal communication with ma'am. She says that I can do it in various types of surgery with very good results, where they have done an ab externo cyclodialysis with a trabeculectomy. They have done it mainly in post-keratoplasty eyes, which we know are extremely difficult for controlling the intraocular pressure, but she has done it in other conditions also, stating that it is very good. And in post-keratoplastic eyes, there was no decrease in graft clarity, no graft failure, even in eyes followed up for 2 years or so. Now, more the merrier. So we have Dada et al. They did a trabeculectomy with cyclodialysis and a 3-site implantation. A 3-site implantation of Ologen, subconjunctival, subscleral, supraciliary, that is within the cyclodialysis cleft in eyes with advanced glaucoma. And I'm reminded of what Dr. Vanita showed yesterday, where she combined procedures and found the effect to be extremely good in advanced glaucoma. Am I not right, Vanita? So here it is that they have used 3 techniques and found that it is better. They have also used an illuminated microcatheter assisted circumferential trabeculectomy, trabeculotomy, and we know that the method which is mainly done in congenital glaucomas is trabeculectomy with trabeculotomy. Here they used a microcatheter with good results. And this is a video which I borrowed from Dr. Tanuj because I found this thing very interesting. Way back in 2010 or so, we used to do deep sclerectomy. Then because its pressure difference, it was not too good. That is why we stopped doing it. And here we find that they have utilized deep sclerectomy with trabeculectomy in order to improve the results of trabeculectomy. There's device-modified trabeculectomy also, and in which I will just try to show you. Can I just finish up this, my last slide? And this is a device-used one that is an express shunt. Again, express shunts are no longer being, probably in India at least. And here you can see, this is a very, very old video of mine, which are done in Base Hospital, Delhi Cant, and it works. Because now these patients are still coming to me, and I find that the pressures are maintained on drugs. So it is not that it does not work, and it's a very safe surgery, and you can see actually the result that nicely the aqueous is draining out. And here you can see the aqueous shunt. This is probably 2 years post-op. Thank you so much for your patient hearing.
Thank you so much, ma'am, for highlighting the nuances of one of the most commonly done surgeries by our glaucoma specialists, and also enlightening all of our audience on how to make it safer for a long term.